So today I will talk about the autoimmune polyglandular syndrome. I will try to cover this topic in next 25 to 30 minutes. Autoimmune polyglandular syndrome are insidious and are characterized by the circulating autoantibody and lymphocyte infiltration of the affected tissues or organ, and which eventually lead to the organ failure. It is a constellation of more than two endocrine gland insufficiency as well as the disorder of non-endocrine organ. The syndrome can occur in patients from early infancy to old age, and even the new component of given syndrome can appear throughout the life, as late as in the even the fifth decade. And there is a marked variation in the frequency and the pattern of autoimmunity in the affected patient and their family, and the risk of development of the various specific autoimmune disease is most likely due to the combination of genetic susceptibility and the environmental factor. So in general, these disorders are divided into two major categories, usually APS type 1 and APS type 2. But some group have further subdivided this APS 2 into APS 3 and APS 4 also, depending upon the type of autoimmunity involved. Actually, this type 1, type 2 mainly given in the very standard textbook like in uh, Harrison's Principle of Internal Medicine and the William textbook of endocrinology. But most of the review articles by various renowned authors, they subdivided into these um, type 1, type 2, type 3, and type 4. For just simplify my presentation, I am just covering, I've grouped into like type 1 and type 2. So in type 1, mainly it is a APS1. It is consist of Addison's disease, hypoparathyroidism, and mucocutaneous candidiasis, apart from the other endocrine and non-endocrine. This individually will see in respective sections. And other is autoimmune polyendocrine syndrome type 2. It is usually consists of Addison disease, type 1 diabetes, and thyroid disease. It can be Graves' disease or autoimmune thyroiditis. Some other endocrine polyendocrine disorders are known, like one important is IPEX, and other also important. We sometimes do see the such patient in our like OPD, like insulin autoantibody syndrome. And this classification of type 1, it is a combination of chronic candidiasis, chronic hypoparathyroidism, Addison disease. Type 2 is Addison disease should always be present, and with thyroid autoimmune disease and or type 1 diabetes mellitus. Type 3 is a thyroid autoimmune disease associated with other endocrine disease, but it excludes the adrenal disease. And type 4, if the diagnosis, it is a diagnosis of exclusion with two or other more specific autoimmune endocrine syndrome that cannot be assigned either to type 2 or type 3. So like in this diagram, what I want to show is the main manifestation of autoimmune polyendocrine syndrome type 1 and type 2, and X-linked of immunodysregulation polyendocrinopathy and enteropathy, that is IPEX. So in this we can see the primary adrenal insufficiency, the characteristics of both APS1 and APS2, while the type 1 diabetes is a characteristics of APS1, APS2, and IPEX. And other thing, here you can see the commonest endocrine organ affected in APS1 is, apart from non-endocrine, that is a mucocutaneous candidiasis, is parathyroid gland, adrenal gland, and gonads. While in type 2, the commonest organ affected is the thyroid, pancreas, and adrenal. This APS1 is also known as the autoimmune polyendocrinopathy candidiasis ectodermal dystrophy. There is an APSED, and it is characterized by the chronic candidiasis and multiple autoimmune disease. To say it is APS1, two of the three should be present. That is a candidiasis, hypoparathyroidism, adrenal insufficiency. And usually all these three is seen by the second decades. And it is a rare autosomal recessive disorder with the complex picture discovered over the decade. And it is a disease of immune dysregulation. And there is a mutation in particular autoimmune regulatory gene, that is AIRE gene. So as far as the prevalence is concerned, it is a prevalent in some community, mainly the Iranian Jews, where the prevalence is 1 in 9,000. Other more common prevalence found in Sardinians, Finns, and other community also this prevalent. It is prevalence is little rare. So the three most common components of this APS1 is candidiasis, hypoparathyroidism, and adrenal failure. And it is tend to appear early. And the incidence rate of candidiasis was highest in infancy and is gradually decreased thereafter. Hypothyroidism, it is usually peak in like third year to fifth year. And adrenal failure, it is peak in about in 11 to 15 years. So the other closely associated autoimmune disorders are gonadal failure, as already mentioned. It can be found in the 60%, mainly in the female patient. Intestinal malabsorption, chronic active hepatitis is around 1/4 of the patient. Hypothyroidism and type 1 diabetes are a little less common. And other non-endocrine manifestations are alopecia, vitiligo, keratopathy, enamel hypoplasia, nail dystrophy. But other important thing is sometimes this early manifestation, they can present prior to the symptoms and disease described, like typical presentation, like hepatitis, keratoconjunctivitis, periodic rash with the fever, chronic diarrhea, severe obstipation, alopecia, and vitiligo. And the additional clinical feature, they can develop to the fifth decade of the life in these patients. So here we can see the majority of the patients, like it was like seen in many like case series. Majority of the patient will have a 3 to 5 manifestation, and some of which not appear until the fifth decade. Therefore, all patients need lifelong follow-up for the detection of any component of the disease. Other important thing was like in some study they have shown that it was a combination of case series. 78% has a non-endocrine manifestation of APS1 before the first endocrinopathy, and the initial non-endocrine manifestation was like in APS1 was oral candidiasis in 60%, intestinal malabsorption was seen in 9%, and keratopathy was the 4%. So the classical form of APF1 is an autosomal recessive disorder, and it is caused by the mutation in autoimmune regulatory gene, that is AIRE gene. So just we'll see that what is this AIRE gene. It is a gene located on chromosome 21 long arm, and the highest concentration is the medullary thymic epithelial cell as well as in the dendrite cell. But it is also found in the lymph node, spleen, and the fetal liver. And the important thing, this gene encoded transcriptional regulatory protein, and it has been localized in the uh, nucleus. So this, what does this do actually? This array operate in the nucleus to promote the expression of thousands of different tissue specific antigen. And this peptide fragment of the TSA, that is the tissue specific self antigen, are displayed on the MSC, that is on the major histocompatibility complex molecule, to help promote the deletion of autoreactive cell that can be generated in the thymus from the random gene rearrangement of T receptors. So this autoimmune regulatory gene array function to maintain the tolerance by promoting the display of self antigen in the thymus. So here we can see, like just to repeat what I say, in the case of like normal central immune tolerance, the autoimmune regulator, that is array, that is expressed in the MTEC, that is the medullary thymic epithelial cell, promote the expression of tissue specific antigen. which are displayed on the surface. This autoreactive T cell with the affinity of cell protein either die by apoptosis or become FOXP3 expressing regulatory T cell. But so if there is AIRE deficiency, then what will happen? So when there is AIRE is lacking, the tissue specific antigen are not displayed on this MTEC surface, and autoreactive T cell escape to the general circulation and peripheral lymphoid organ where they can cause the autoimmune reaction in APS. So there is a loss of negative selection, and because of this AIRE deficiency. So there are around 100 different mutations are seen in this gene, and the commonest which are written in the red letters are present mainly on the card domain, and the written in the green letter, they are the dominant negative mutation which are less common as compared to the these written in the uh, red letters. So these now these individual who are having the like who's who are having the autosomal dominant mutation, they are though less common. They are having the non-classical form of APS, and their clinical features are milder and usually present the latter. As far as the clinical spectrum is concerned, classical APS develop very early in the life and often in infancy. Chronic mucocutaneous candidiasis without sign of systemic disease is often the first manifestation, and it can be seen as early as in the first month after the birth or up to the age of 21 year, with peak occurrence in the early childhood. Uh, this chronic mucocutaneous candidiasis can present in 73 to 100% of all the patient, and it usually affect the nail, dermis, and oral, vaginal, and esophageal mucous membrane. In majority of the cases, the infection is limited to not more than 5% of the skin surface. In rare cases, this can cause some important complication like esophagitis, esophageal with the structure and retroesternal pain. So this chronic mucocutaneous candidiasis is considered the clinical expression of an immunological selective T cell deficiency with an inability to respond to the candid antigen. So these patients in general have a normal B cell response of the serum antibody to the candidal antigen, which is considered important in preventing the development of systemic candidiasis. And the etiology is associated with anti-cytokine autoantibody, and it depresses the production of this cytokine by peripheral blood mononuclear cell. So anywhere along the GI tract, if this mucocandidiasis is left untreated, it can cause squamous cell carcinoma of the oral cavity or esophagus. Other important presentation is hypoparathyroidism, and it is usually developed next and then followed by the adrenal insufficiency. The time from the development of one component of the disorder to next can be many years, and the order of disease appears in variables. So parathyroidism is found in approximately 85% of the cases, while the Addison disease in approximately 80% of the cases. And next common is gonadal failure, and it is more common in the female as compared to the male. And hypoplasia of dental enamel also occur frequently in about 77% of the cases. The other endocrine disorder that occur less frequently in APS1, these are type 1 diabetes, autoimmune thyroid disease, and the frequency of like non-endocrine manifestation also present, like alopecia can be seen in 40% of the patient, vitiligo in 26%, intestinal malabsorption in 18% of the patient, while pernicious anemia can be seen in 31% of the patient. An unusual and debilitating manifestation of the disorder is development of refractory diarrhea, obfuscation that may be related to autoantibody mediated destruction of this enterochromaffin or enterochromaffin-like cells. And the incidences of many of these disorder peak in the first or second decade of the life. So how these are diagnosed actually? So diagnosis of the APS is highly likely when 2 or more of the primary component is present. The sibling of affected patient should be considered affected even if only one of these disorder is present. So sequence analysis of array of mutation may be helpful in identify the subject with APS1. So any patient with any of the component disorder deserve full careful follow-up to watch the development of additional disease. So this is a very important part of the follow-up of this APS patient. Autoantibody against interferon, mainly to the alpha and the omega, have been identified in almost 100% of the subject with APS1, regardless of the age at what they have screened. And it is especially in the case, it is important, especially in the case where the mutation analysis is complicated and autoantibody arises independent of type of array gene mutation, and it is not found in other autoimmune disorder. So like what here we can see the uh, development of the classic diagnostic dyad was delayed almost like in this study. This was paper from the group of the patient from the America, and it was published in JCI 2016. What they have found, the development of this classic diagnostic dyad was delayed up even like at mean of around 7.3 years. But what the important thing they have found, the 80% of the patient develop a median of 3 non-triad manifestation before a diagnostic dyad, and only 20% patient had their 2 manifestation among the classic dyad. So like arterial eruption, intestinal dysfunction, and enamel hypoplasia were prominent among the early manifestation as compared to the classical of which the require for the diagnosis. So in such patient, minor component can be very helpful in the diagnostic hint. And because of the availability of the array sequencing and specific autoantibody test have uncovered the milder and more atypical cases of APS in the person without 2 of the 3 main component. So in such cases like this, APS1 can be diagnosed even they have very classic features of APS1. So diagnosis of each underlying disorder should be done based on their typical clinical presentation. Like mucocutaneous candidiasis may be present throughout the gastrointestinal tract, and it may be detected in the oral mucosa or in from the stool sample. And many times the evaluation by gastroenterologists to examine the esophagus for candidiasis or secondary stricture may be merited based on the symptoms. Other gastrointestinal manifestation of APS1 include malabsorption and obstipation. May also bring these young patients to the attention of gastroenterologists for first time evaluation. Specific physical examination finding of hyperpigmentation, vitiligo, alopecia, tetany, and sign of hyper and hypoparathyroidism should be considered as a sign of development of the component of the disorder. The development of disease-specific autoantibody assay can help confirm the disease and also detect the risks of future disease. For example, detection of anti-cytokine antibody to interleukin 17 and 22 would confirm the diagnosis of mucocutaneous candidiasis due to APS1. Similarly, the presence of anti-21 hydroxylase antibody or anti-17 hydroxylase antibody, which is commonly found in adrenal insufficiency associated with APS1, this would confirm the presence or risk of Addison's disease. Other autoantibody found in type 1 diabetes, like GAT65, pernicious anemia, and other component should be screened for regular basis, preferably uh, like 6 to 12 months of the interval. Laboratory tests, including the complete metabolic panel, phosphorus, magnesium, TSH, ACTH, hemoglobin A1C, plasma vitamin B12, and complete blood count with peripheral smear looking for Howell Jolly body should also be performed at this time point. It is also seen that antibody against the NALP5 were identified in the 49% of the patient with APS and hypoparathyroidism. And this antibody was absent in APS without hypoparathyroidism. So, and the detection of abnormal physical finding or test result should prompt subsequent examination of relevant organ system, like presence of Howell Jolly body indicate need for ultrasound of the spleen, because it is usually found when there is a splenism. And other important thing, if there is a massive accumulation of autoimmune diseases in the family, especially with early age, and it indicate usually the it can be because of monogenic disease, and probably because of non-classic APS one, especially if the vitiligo and pernicious anemia are prevalent. And lastly, for the family member of APS1 patient, genetic diagnosis allow the avoidance of unnecessary follow-up of family member when AIRE mutations are not present. And genetic testing of mutation in the AIRE genetic identify the APS1 associated mutation in the relative of APS1 patient prior to the occurrence of symptoms and sign, allowing the early intervention and helping prevent the potentially fetal complication from untreated endocrine insufficiency. So these are the recommended evaluation for the APS1, which will include the history, physical examination, basic biochemical, hematological, hormonal evaluation, and antibody against various antigens. So as far as the treatment and follow-up is concerned, patient should have a minimum of 2 follow-up visits per year because of complexity of the entity, and asymptomatic carrier of mutation should be followed at least annually. It is mandatory to check all the sibling of the patient with APS1, even if the siblings are adult and doing well. And we should replacement the deficient hormone. Adrenal insufficiency can be masked by the primary hypothyroidism by prolonging the half-life of cortisol. And the caveat therefore is that replacement therapy with thyroid hormone can precipitate an adrenal crisis in undiagnosed individual. Hence, all the patients with hypothyroidism and possibly of APS should be screened for adrenal insufficiency to allow the treatment with the glucocorticoid prior to initiation of the thyroid hormone replacement. And as for the treatment of chronic mucocutaneous candidiasis is concerned, it is generally managed with the oral mycostatin or oral amphotericin B to avoid the problem of drug resistance. And azole drugs should be avoided if possible, because it inhibits the steroidogenesis, and such inhibition in association with the risk of inducing adrenal insufficiency, especially in the patient who have unrecognized Addison's disease. It is also associated with the transient elevation of the liver enzymes level and occasionally with the hepatitis. So we have to be very careful when using the azole drugs. Fluconazole is associated with lower frequency of hepatitis and does not inhibit the steroidogenesis, so it can be a good choice. Infection often recover when the drug is discontinued and the dosage is decreased. Sometime in severe cases of disease involvement may require the systemic immunomodulatory therapy. Hypothyroidism is managed with the oral vitamin D derivatives in combination with the calcium and magnesium supplement, but sometimes it is difficult to control because of concomitant malabsorption. If the asplenia is developed, then patient should be advised for vaccination against pneumococcus, meningococcus, H. influenza, type B, and influenza. Sometimes these patients require treatment with the immunosuppressive agent. So condition associated with APS1 such as keratitis, pneumonitis, hepatitis, or enteritis may require immunosuppressive treatment. Topical glucocorticoid and cyclosporin may be helpful in the treatment of keratitis, but reversible corneal scarring develop in many patients who receive such therapy. This rituximab have been reported to have a beneficial effect on the pneumonitis and malabsorptions, and cyclosporin has been improved the pancreatic insufficiency. Autoimmune hepatitis in the patient with APS1 can be aggressive, and it can lead to the fulminant failure and the death if not treated promptly with high doses of glucocorticoid and azathioprine. But there is a still lack of data, and more study of immunosuppressive treatment are needed. As for the natural course and mortality is concerned, overall mortality is increased, but the course of disease is very widely. So at one spectrum, many patients are doing quite well, But on other hand, those with the labile hypoparathyroidism, adrenal failure, diabetes mellitus with disfiguring universal alopecia, extensive vitiligo, severe oral and nail candidiasis, and depression with the serious concern for the future. Life expectancy depend upon the severity of the disease and most unknown factor determining, like uh, quality of the management, including the psychosocial support, intelligence of the patient, family, and their ability to assume the responsibility. And now we'll move to the APS2. Uh, so it have been characterized by the at least two of the following three endocrinopathy. Type 1 diabetes, autoimmune thyroid disease, and Addison disease is much more common than type 1, and its prevalence is 1 in 20,000. It commonly occur in third and fourth decade, and usually like middle-aged female, three, three times more common in women. Uh, Dominant mode of transmission, it is a polygenic inheritance. It has been estimated that as many as 1/4 of the patient with one autoimmune disease will develop another during their lives, and this happen in about 50% of the patient with autoimmune adrenal insufficiency. So here what we can say, it can affect the these patient can develop like other condition apart from what I said, like celiac disease, alopecia, vitiligo, primary ovarian insufficiency, and pernicious uh, anemia. These additional manifestations are more frequent among with the patient of APS2 who are having the Addison's disease. What we can see in the upper graph, type 1 diabetes was the first component disease of APS in half of the patient which appear, whereas the Graves disease and Hashimoto's thyroiditis, Addison's disease, and vitiligo are less likely to be the first component of the disease. And other important thing regarding the their appearance of the disease at what age, the age at manifestation for APS, like type 1 diabetes usually appear at the mean age of around 27 years, while the other component appear later. It range from 36 to uh, 40 years. The most frequent, here we can see the most frequent coexistence of APS2 component disease was between type 1 diabetes and thyroid disease, and less commonly coexistence occur between thyroid and adrenal disease, type 1 diabetes and vitiligo, as well as the thyroid disease with the vitiligo. And here we can like in the first graph on the left side, the time interval between manifestation of first and the second autoimmune endocrinopathy varies considerably in APS2, with the longest time interval between type 1 diabetes and thyroid disease, and between vitiligo and thyroid disease. But short time interval was between Addison's disease and the thyroid disease. And in this right side lower graph, we can see the antibody, that TPO antibody was more frequent as compared to the other antibody. As far as the pathogenesis and immunogenetic is concerned, approximately half of the patient with APS have a relative with other autoimmune disorder, and most autoimmune disorder with the predominant non-genetic determinant of susceptibility to APS2 reside in human leukocyte antigen, that is HLA antigen. Uh, the class 2 HLA haplotype, mainly the DR3 and DR4, are strongly linked with the component disorder of this syndrome. And it is highly likely that there is a complex interaction between the non-HLA loci and environmental factor. From genetic study of APS2, it is known that the same gene and same nucleotide polymorphism are associated with several organ-specific autoimmune disease. Uh, Other gene association with well-established risk of APS2 include those encode like CTLA4, protein tyrosine phosphatase non-receptor type 22, transcriptor regulatory protein, and CD25 interleukin 2 receptor. Despite the major advancement in the identification of gene, the heritability of APS2 is a complex. Clinical features, the important thing is when one of the component disorder is present, and associated disorder occur more commonly than in general population. And other important things, circulating organ specific autoantibody are often present even in the absence of overt clinical disease. For example, in patient with type 1 diabetes, there are 15 to 20% risk of hypothyroidism, 5 to 10% risk of celiac autoimmunity, and around 1.5% risk of adrenal autoimmunity. The risk of autoimmunity is greater in the relative of patient with APS2, and APS2 family with Addison disease up to 15% relative were found to have a 21 hydroxylase autoantibody, and anti-islet cell autoantibody are TTG autoantibody, that is a celiac disease associated antibody. Here what I want to show here, that like in patient with Addison's disease who are not having APS2, the most frequently autoimmunity was associated with the thyroid disease and the diabetes, and significant proportion of the patient exhibited thyroid and diabetes related autoimmunity without yet developing the disease over the average follow-up of the 10 years. As far as the clinical feature is concerned, among the patient with type 1 diabetes, thyroid autoimmunity, celiac disease coexist with the sufficient frequency to justify the screening. A significant fraction of the patient with type 1 diabetes and thyroid peroxidase and autoantibody develop thyroid disease. And in one study, it has shown that after the follow-up more than 15 years, 80% of the patient with thyroid peroxidase, autoantibody, and type 1 diabetes become hypothyroid. Because of chronic development of organ-specific autoantibody, patient with the syndrome and their families should have a repeated endocrine evaluation. In a family in which the syndrome have been documented, relatives should be advised for early symptom and sign of principal component disease. And the relative of the patient with multiple disorders should have a medical history, physical examination, screening every 3 to 5 years with measurement of anti-islet cell autoantibodies, sensitive TSH, and measurement of serum B12 levels. If there are symptom or sign, or if 21 hydroxylase autoantibody are present, the patient should have an annual assay of basal ACTH level and post-synaptic stimulation test for the cortisol. With the identification of TTG has a major endomysial autoantibody of the cilia, and it has demonstrated that 10 to 12% of patients with type 1 diabetes have a TTG autoantibody. Dr. Arpan, can I have 5 minutes more, or like should I have short? Actually, not sure. Hello.
Yeah, I think within 5 minutes you finish, please.
Okay. So thank you. The prevalence of TTG autoantibody have higher in diabetic patient with HLA, DQ2, and important thing it can develop in the patient with the long-standing diabetes as well. In the least one cohort has shown that the increase in the patient with the even adult onset type 1 diabetes compared with the childhood onset. If it is left untreated, symptomatic celiac disease is associated with increased risk of gastrointestinal malignancy, especially the lymphoma. So as far as diagnosis is concerned, currently there is no unique test to detect the APS2 in patient, but testing of autoantibody may be helpful in assessing the disease risk, since the relevant autoantibody are frequently detected year before onset. And diagnosis of APS2 require an understanding of the risk of additional autoimmune disease in the patient with the single autoimmune endocrine disorder. A thorough history and physical examination may identify the symptom or sign of the additional autoimmune disorder. And screening of disease can include the screening for marker of autoimmune diseases and assay for the glandular function. Important thing like adenal autoantibody reacting with the recombinant 21 hydroxylase usually precedes the development of Addison disease. Screening with 21 hydroxylase antibody, autoantibody may identify the patient with antibody but have a normal production of cortisol in response to ACTH. Annual screening with the basal level of corticotropin with follow-up synaptic stimulation testing is an effective strategy for identify the adenal insufficiency in patient with 21 hydroxylase autoantibody. As far as the treatment is concerned, it should be focused on the replacement of the missing hormone in accordance with the current guideline for treating the main component of the APS2. And other important thing, physicians should be particularly aware that the patient with APS2 is an increased risk for development of another organ-specific autoimmune antibody. Many of the component disorder of this syndrome have a long prodromal phase and are associated with the expression of autoantibody before the manifestation of the disease. As far as the prevention of the APS2 is concerned, the immunotherapy was tried, and mainly in the diabetic, the various immunotherapy was tried, but only it has prolonged the honeymoon phase of type 1 diabetes, but none has achieved any long-term success. So active research using the new approach and combination therapy may change the treatment of this disease or other autoimmune conditions that share the similar pathway. In patient with APS2 and autoimmune hypothyroidism, it is essential to check the adrenal function before initiating the treatment of hypothyroidism. This I have mentioned in APS1 also. So it was very essential to check the adrenal function. And other important thing is the education is also very important because the patient must understand the need for the lifelong medication, and that the dose will need to be increased at the time of the stress or illness, especially in the cases of Addison disease. Other is just one slide on the immune dysregulation of polyendocrinopathy, enteropathy, X-linked, that is IPEX syndrome. It is a rare disease. It is because of dysfunction of the transcriptor factor FOXP3. It is characterized by the dysfunction of the regulatory T cell and subsequent autoimmunity and primary manifestation manifesting as a type 1 diabetes. The thyroid gland is the other gland commonly involved, and it is inherited as in the male via the X-linked recessive manner. These are other endocrine gland which very rare. So this I'm just going to skip it. So thank you for your kind attention.